Good afternoon. My name is Mary Fristad, and I am giving a talk on Omega3 and Therapy studies, oats for depression and bipolar disorder in children, for an SSCP Virtual Clinical Lunch. My disclosures are that I receive royalties from the American Psychiatric Press, Guilford Press, and Child and Family Psychological Services Incorporated. I receive honoraria from the Postgraduate Physicians Incorporated and the American Occupational Therapy Association. Omega3 provided the supplement and placebo for the study I'll be describing today. My objectives are to review the rationale for studying omega-3 and psychotherapy in the treatment of childhood mood disorders. I will provide an overview of oats and the main findings from our oats studies. To begin with, in depression in youth, we know that 20% of youth under the age of 18 experience a major depressive disorder. In childhood, the prevalence is 2% for major depression and about 0.5 to 1.7% for dysthymic disorder, and an additional 5 to 10% of youth experience subsyndromal symptoms of depression. We know that depression in youth is linked to significant functional impairment, including risk for disruptive behavior and substance abuse disorders. Recurrence rates are high. If you're a betting person, bet that the depression will come back. 40% of youth will experience a recurrence within 2 years, and 70% will within 5 years. Unfortunately, treatments to date have mixed results at best. Given the less than robust response to pharmacologic interventions, alternative physiologic interventions have been considered, including omega-3 fatty acids. Medications for children with depression have some limitations. We know there's a twofold increase, a 4% versus 2% increase in risk for suicidal behavior or ideation for medication over placebo. This resulted in the year 2004 in a black box warning from the FDA. Bridge and colleagues in 2007 found a smaller effect, a less than 1% rate of suicidal behavior or ideation, but noted that concern for increased incident of treatment-emergent suicidality is warranted. And in September 17, 2015, the New York Times had a headline, "Antidepressant Paxil is unsafe for teenagers, analysis of original data finds." The Treatment of Adolescent Depression study, or TADS, demonstrated superiority of combined treatments for adolescents with major depressive disorder. We know that the efficacy of antidepressants for children is questionable. Fewer studies have been conducted with children aged 6 to 12 compared to adolescents, and of the 15 trials of antidepressant medications for major depressive disorder, only 9 included children, 539 out of a total of almost 3,000 participants, and none have focused solely on children. Only fluoxetine has been shown to be significantly better than placebo in children, possibly due to a high placebo response rate, and no medication psychotherapy combination trials have been conducted with children. There have been TADS done with adolescents. Given concerns about treatment-induced suicidal ideation and suicidal behavior, as well as the questionable effectiveness of antidepressants in children, parents may seek other treatment options, such as psychotherapy or dietary supplements. Turning to bipolar disorder, what do we know about the national trends in the outpatient diagnosis and treatment of bipolar disorder in youth? In an article published in 2007 that received quite a bit of press nationally, Moreno and colleagues, with Mark Olson being the senior author, compared outpatient visits in 1994-95 and 2002-2003 for individuals aged 0 to 19 compared to those aged 20 and older, diagnosed with bipolar disorder. They contrasted demographic, clinical, and treatment characteristics. Patient visits, almost 1,000, were tallied from the National Ambulatory Medical Care Survey. The estimated annual number of office-based visits, not the number of patients, but the number of visits with the diagnosis of bipolar disorder, increased from 0.0025% in the year 1994-95 to 1% in the year 2002-2003 for youth. The rate essentially doubled for adults during that same time period. So in my introductory statistics book in graduate school, the little saying at the beginning of the book was that there are lies, damned lies, and statistics. And this is a great example of that. If you multiply 0.0025% by 40, indeed you get to 1%, but a 1% prevalence rate is not unusually high. They estimated the annual number of office-based visits for a diagnosis of bipolar disorder, and there you see the rates. 25 out of 100,000 visits attributable to bipolar disorder is quite low. We believe that 50% of patients have their onset of bipolar disorder prior to the age of 19. This suggests that the number of patients should be roughly half that of adult figures, suggesting further a 180-fold underutilization of visits by youth in 1994-1995. What do we know about problems with medications for bipolar spectrum disorders? While clearly beneficial for mood regulation, second-generation antipsychotics and mood stabilizers frequently have adverse effects. McIntyre and Gerald in 2008 published a study in which they compared over 4,000 youth who had been prescribed SGAs or other antipsychotics to over 4,500 youth not on medications. They found higher rates of a variety of adverse cardiometabolic effects. Correll et al. In 2009 published in JAMA an open-label study of SGAs in inpatient youth. After 12 weeks, they reported significant increases in weight, triglyceride levels, total cholesterol, non-HDL cholesterol, and triglyceride-HDL cholesterol ratios. This places youth at risk for obesity, hypertension, and type 2 diabetes mellitus. Additional side effects reported included drowsiness, lethargy, orthostatic hypotension, nasal congestion, rigidity, tremor, and dystonia. So putting this together, we know that medications are an important component to a comprehensive treatment plan for many with moderate to severe mood disorders, be they depressive or bipolar spectrum disorders, but medications carry with them a significant burden, and the risk-benefit ratio needs to be carefully considered. I think everybody would agree that minimizing the number and dose of medications that is used is likely a good thing. Turning our attention to nutritional interventions, some general comments. These can be used in conjunction with psychosocial interventions and oftentimes with medication. They have the potential for a more favorable risk-benefit ratio than currently available SGAs and mood stabilizers. And today we'll be focused on omega-3 fatty acids, but there's also been considerable work done with a multi-nutrient complex as well as N-acetylcysteine. Focusing on omega-3 fatty acids, we know that omega-3s are one of two series of essential fatty acids, the other being omega-6. They complement each other. Omega-3 appears more important for neuronal function. Critical omega-3s are long-chain 20-carbon EPA and DHA. These can be inefficiently anabolized from dietary ALA by consecutive desaturations and elongations in the presence of normal enzymes. And so for that you need good nutrition. They are incorporated into neuronal membranes and form scaffolding for receptors and ion channels. So really the structure of the brain, we need to have the omega-3s. Owen and colleagues posited 4 pathways for omega-3 depletion that may link to depression. Ratios of DHA to other fatty acids affect membrane fluidity and the functioning of enzymes, ion channels, and receptor binding. Omega-3 concentrations impact neuroplasticity and cell survival. Omega-3 concentrations affect gene expression. And omega-3 availability affects production of pro-inflammatory cytokines, which are elevated in depressed patients and inhibited by some antidepressants. Omega-3 supplementation may help improve brain structures in these areas, which are reduced in people with mood disorders. Patients with bipolar disorder who take omega-3 demonstrated lower T2 values, suggestive of increased membrane fluidity. The mechanism of omega-3's impact on depression is being pursued in tandem with research about omega-3 supplementation in mood disorders. A limitation, however, of omega-3 studies are the highly variable dosages and combinations of EPA and DHA studied. The field has not yet reached consensus on the ideal combination of EPA and DHA. What do we know about changes over time in dietary omega-3? In a review written by Russ Sheffer in 2008, he reports that back in our hunter-gatherer ancestry days, the ratio of omega-3 to omega-6 was roughly 1 to 1. The modern ratio is more like 1 to 100 or greater. A majority of American adults obtain less than 100 milligrams of EPA and DHA in their diets, and the rates are worse for children. Parker et al. 10 years ago reviewed 6 studies that examined the relationship between consumption of foods high in omega-3 and mood impairment. 5 out of 6 of these studies demonstrated a direct relationship between seafood consumption and depressive symptoms. There was one negative study, but it had low levels of omega-3 intake, and levels were based on self-report, not blood levels. In a cross-sectional study of over 20,000 Norwegians aged 40 to 49 or 70 to 74 years of age, 3.5% had high levels of depression, almost 9% consumed cod liver oil daily, which is quite rich in omega-3. Their prevalence rate was 2.5%, the remainder 3.8%. This was a significant difference after adjusting for age, gender, drug, and alcohol consumption, and physical activity. Negative association between high levels of depression and the duration of cod liver oil intake. In another epidemiologic study, there was a cross-sectional study of about 1,400 persons in France, all age 65 or older, mean age of 75. 8.4% displayed clinically relevant depressive symptoms. They had significantly lower EPA levels than other participants. The relationship between depressive symptoms and EPA levels remained significant after adjusting for age, sex, marital status, antidepressant treatment, cognitive functioning, hypercholesterolemia, number of drugs per day, and weight loss. Turning our attention to treatment, Garland and colleagues published in 2007 in the British Journal of Psychiatry a comparison of nutritional variables in 40 adults who self-harm versus controls. The self-harm group had significantly more psychopathology, lower cholesterol levels, lower levels of circulating omega-3 and omega-6, and lower CNS levels of DHA and EPA than controls. Impulsivity and depression scores were inversely related to omega-6 and omega-3 levels. In a double-blind RCT, Hallahan and colleagues tested EPA and DHA as an adjunctive treatment for 49 adults who self-harm. 22 received 1.2 grams of EPA and 0.9 grams of DHA for 12 weeks. 27 received matching placebo. The omega-3 group had greater improvement compared to controls on measures of depression, suicidality, and daily stress. The omega-3 participants were more likely than the placebo participants to report no suicidal ideation, 64% compared to 30%. In a treatment study of substance abusers published in 2008, 22 adults were enrolled in a double-blind randomized controlled 3-month trial. 11 received 3 grams of omega-3, 2.25 grams of EPA, 500 milligrams DHA, 250 milligrams of other omega-3s. 11 received a matching soybean oil placebo. At baseline, all participants were consuming less than 35% of the RDA of omega-3 according to the International Society for the Study of Fatty Acids and Lipids, and less than 5% of the RDA according to Hibble and colleagues' guidelines to protect against cardiovascular and psychiatric diseases. Improvement was significant, with the omega-3 group outperforming controls on the profile of mood states, on the anger and anxiety subscales. At end of trial, EPA, DHA, other omega-3 polyunsaturated fatty acids, and total long-chain polyunsaturated fatty acid blood levels correlated with improvements in anger and anxiety. What do we know about mood disorders? In a meta-analysis of 10 studies published in 2007, patients with mood disorders who were taking omega-3 for 4 weeks or longer, there was a significant antidepressant effect of omega-3 for the overall sample with an effect size of 0.61, for patients with clearly defined depression with an effect size of 0.69, and for patients with bipolar disorder, again with an effect size of 0.69. How about depression in children? Nemitz and colleagues published 10 years ago an RCT of 28 children ages 6 to 12 with major depression in a 16-week trial. 13 received omega-3 in a 2-to-1 EPA to DHA ratio. 15 received placebo. 8 children dropped out and were deleted from analyses, 5 from placebo, 3 from omega-3. There were no clinically significant side effects reported. They found that there was a greater than 50% decrease in depressive symptoms, 7 out of 10 on omega-3 versus none on placebo. Remission was reported for 4 out of the 10 on omega-3 versus none on placebo. Most of the response noted at week 16 had already been achieved by week 12. Findings support omega-3 as potentially beneficial for childhood depression. The risk-benefit ratio may be superior to that of traditional antidepressants. In terms of bipolar disorder in children, Janet Wozniak and colleagues published in 2007 an 8-week open-label trial of omega-3 fatty acids using a 7:1 EPA to DHA ratio. This was monotherapy treatment, with the only exception being stimulants for children with ADHD. They studied 20 outpatients ages 6 to 17 with bipolar spectrum disorders. The dose was widely varied from 1.3 to 4.3 grams of omega-3 daily, the majority of whom were taking 2 grams or more per day. 16 participants completed the entire trial. Dropouts were due to lack of efficacy, not side effects. They found that omega-3 caused few mild side effects, usually GI in nature. Manic symptoms reduced by 30% in half of the sample and reduced by 50% in a third of the sample. Those participants on 2 grams or more per day improved more than those on less than 2 grams. Depressive symptoms, 40% were rated much or very much improved. In a really striking study, Amminger et al. In 2010 published in the Archives of General Psychiatry a prevention of psychosis trial. They followed 81 participants aged 13 to 25 who were at ultra-high risk for psychosis in a 12-week RCT. Omega-3 was 1.2 grams in a 1.5 to 1 EPA to DHA ratio compared to placebo. All participants received 9 sessions of psychosocial treatment, plus case management, plus emergency sessions scheduled on a PRN basis. There was then a 40-week follow-up. 94% of the participants completed the entire 1 year of the trial. Conversion to psychotic disorder was significantly lower, 4.9%, in those taking omega-3 compared to 27.5%, or a over 5-fold difference for those on placebo. The number needed to treat was 4. This is a statistic that reflects the number needed to prevent one person, in this case, from becoming psychotic. And 4 for a number needed to treat is similar to what was found in 2 recent studies of atypical antipsychotics. Following the positive and negative syndrome scale, the positive, negative, general, and total scores were all preferential for those on omega-3 at 12 weeks, 6 months, and 12 months. There was surprisingly no difference between groups on the Montgomery-Åsberg Depression Rating Scale. However, on the Global Assessment of Function, omega-3 again outperformed placebo at 12 weeks, 6 months, and 12 months. Reported side effects were comparable for the omega-3 and placebo group, as was adherence to the study capsules and use of augmentive treatment. In a very striking finding, Amminger and colleagues went back a median of 6.7 years later and followed up almost 90% of this cohort. They found that in the brief intervention given almost 7 years earlier, at the 6.7-year follow-up, there was still decreased risk of progression to psychotic disorder, less than 10% compared to 40%, a slower conversion time of those who did convert, and lower psychiatric morbidity in general for those who had been on omega-3. The PANSS total and positive scores, the MADRS, and rates of other psychiatric disorders were significantly lower for those who had taken omega-3, 53% compared to 83%. They also had a lower rate of antipsychotic prescriptions, less than 30% compared to over 50%. Strikingly, only 2 of the original participants in the omega-3 group had remained on the supplement for more than 1 month during the follow-up. I believe the authors were a little surprised themselves in their own findings, and they speculated that perhaps treatment occurred during a critical developmental period, preventing changes associated with an increase in striatal dopamine. This is their working hypothesis. It clearly deserves further investigation. Turning a little bit of attention now to psychosocial issues, what do we know about the psychosocial impact on course of illness for youth with bipolar disorder? At baseline, families of youth with bipolar disorder compared to healthy and ADHD control groups demonstrate less warmth and greater tension and hostility. At 2 and 4 year follow-up, lower maternal warmth predicted faster relapse after recovery from mania, intact families were associated with faster rate of recovery, and of note, medication status was not predictive of illness course. So what do we know about evidence-based psychotherapy for bipolar disorder? In a review that Heather McPherson and I published in 2014 in the Journal of Clinical Child and Adolescent Psychology, at that time there were no well-established treatments. However, there were 2 groups, when we published the report, that were in the probably efficacious category, and since that time, Amy West has published an RCT, and so now we have 3 in that category. And if you look at the work of the Rainbow program, which is the Pavoluri and West program, the program of FFT of Dr. Miklowitz, and our psychoeducational psychotherapy, you'll notice that the active ingredients are really much more similar than they are distinct. And so the category of family psychoeducation plus skill building really could move as a category into the well-established range. In terms of possibly efficacious, cognitive behavioral therapy for adolescents with bipolar disorder, and in the experimental but soon to move up range is dialectical behavioral therapy, followed by the work of Tina Goldstein, and interpersonal and social rhythm therapy, an adolescent adaptation of Ellen Frank's work for adults that has been examined by Stephanie Holostola. So the common ingredients of psychotherapy for youth with bipolar disorder include psychoeducation, being family-based, focused on emotion regulation, and symptom management skills. And so that gives you a little bit of the review of the rationale for studying omega-3 in psychotherapy. And now let me give you a little bit of an overview of our OATS trial. So these were 2 R34s funded by the National Institute of Mental Health. We had 95 children altogether, 72 with depression, 23 with bipolar NOS or cyclothymic disorder. The 2 protocols were identical other than the diagnoses of the children who entered the study. It was a 12-week trial. Children were aged 7 to 14, and they could have had no medications or psychotherapy in the previous month other than stable stimulants for ADHD or sleep aids. And in the trial, children received either omega-3 or placebo. They received either IF-PEP or active monitoring. And so there were 22 kids, 17 with depression, 5 with bipolar spectrum disorder, who received both psychotherapy and omega-3. There were 23 children who received omega-3 and active monitoring, 18 with depression, 5 with BPNOS or cyclothymic disorder. So overall, there were 45 children who received omega-3. There were 26 children who received psychotherapy and placebo, 19 with depression, 7 with BPNOS or cyclothymic disorder. There were 24 children who received no active treatment arm, 18 with depression and 6 with BPNOS. And so altogether there were 48 children who received psychotherapy. Again, for a total of 95 children in the study. The average age of all 95 children, 11.2 plus or minus 2.2. 2/3 of the participants were 12 or under, and 1/4 of them were 9 years of age or under. Just over half were boys. 61% were white, 28% were biracial or black. 7% were Hispanic. The average IQ was 103 plus or minus 16. And in terms of specific diagnoses, we had 37 with major depression, 5 with dysthymic disorder, 30 with depression NOS, 11 with BPNOS, and 12 with cyclothymic disorder. Comorbidities were common. Over 3/4 had a comorbid anxiety disorder, 61% ADHD, and 39% disruptive behavior disorder, ODD or conduct disorder. All of the participants received a daily multivitamin mineral supplement to stabilize the general nutritional intake of the children, and they received 7 assessments at screen, baseline, and at weeks 2, 4, 6, 9, and 12. They also received referrals as requested or needed. If we felt ethically that we needed to give a referral to a family, we did that regardless of treatment condition, and they all received money for completing the assessments and free parking. In terms of the parent participants, 91% were mothers, average age 41, 65% white, 33% black or biracial. In terms of capsule adherence, it was pretty high, around the 90% range, 80 to 90%, and fairly similar for the bipolar and depressed cohorts. Therapy attendance averaged about 15 to 16 sessions with no difference between the bipolar and depression cohorts. Side effects were minimal. We monitored constipation, diarrhea, change in appetite, burping, fishy breath, or nausea. The bipolar group had an average score of 1 on a 0 to 6 scale. At week 12, 2 of 4 children who endorsed having any kind of symptom had physical illnesses. And on the depression, all of the scores were equal to or less than 1 on a 0 to 6 scale. In terms of our outcome measures, we used both filtered and unfiltered ratings, and I have a citation if you're interested in understanding what the difference is, but basically with the Young Mania Rating Scale and the Children's Depression Rating Scale revised, those are typically administered in studies in what's called an unfiltered way, meaning that they're not necessarily asked in the context of a mood episode. So we wanted to know in a kind of what you see is what you get, or unfiltered way, what the kids looked like. And then also we used filtered ratings, so we rated the symptom severity only in the context if they were occurring in a depressive episode or in a manic episode, and that's the KSADS Depression Rating Scale and the KSADS Mania Rating Scale. About halfway through the study, we decided we wanted to have a few more measures of behavior that would be dimensional in nature rather than categorical. So we added the Swanson, Nolan, and Pelham, or SNAP, parent self-report, and we gave that at all time points other than the screening because we added it a little too late into the study. So we had the SNAP total score and the SNAP oppositional aggressive subscale scores. At that same time, we added the IBERG Child Behavior Inventory, and so we gave that at baseline week 6 and 12. 38 families received that, and we looked at the intensity and problem scales on the ECB. We also gave the Behavior Rating Inventory of Executive Functioning, or BRIEF, at screen in week 12, and all participants in the study got that. With the BRIEF, we looked at the Global Executive Composite as well as the 2 subscales, the BRI, or Behavior Regulation Index, and the MI, or Metacognition Index. And what did we find? Starting with our bipolar sample, again our N of 23, we found a significant reduction of depressive symptoms. If you follow along the purple line, you'll see a significant decline compared to placebo. The placebo is the dashed line. And here we got an effect size of 1.7, a significant difference. The red line is the psychotherapy, or PEP, with placebo. And that compared to the PEP compared to placebo was an effect size of 0.92. Combined was superior to Omega3. Omega3 is in the blue line. And then we collapsed if they got any PEP versus any active monitoring. The effect size was 1.24. And then we collapsed the 2 conditions that got Omega3 compared to any placebo, and the effect size was 0.48. Using the unfiltered ratings, we again found a significant difference, so that our combined cell, the purple line, compared to the dashed line, and there's our placebo, we got an effect size of 0.81. Comparing PEP to placebo, there's our red line, an effect size of 0.63, and again any PEP compared to any active monitoring, an effect size of 0.63. Any Omega3 compared to any placebo, an effect size of 0.2. And here you see this solid black line indicates what is typically considered remission on the CDR-SR, a score of 28. And so you see that we begin to approach the remission line by the end of study. In terms of reduction of manic symptoms, and here the two black lines, this is the top black line suggests probable bipolar spectrum disorder, and the lower line suggests possible bipolar spectrum disorder. And here we saw that the omega-3 compared to placebo had an effect size of 0.86. Moving to our depressed cohort, we found that in this study where we had lots of TLC, and again everybody got the vitamin mineral supplement, everybody got 7 assessments. When we looked at our overall cohort, everybody got better. So then we looked for moderating effects. And the first one that we looked for was maternal depression. So in the absence of maternal depression, you'll see that all 4 groups improved. The placebo, to orient you, is the black line. The combined is the dashed dot line. PEP monotherapy, here we see this dashed line. And the dotted line is the omega-3 monotherapy. And when I say monotherapy, I'm referring to the one active treatment ingredient. However, if there had been maternal depression present, and here again is that line of 28, which is considered remission on the CDR-SR, again going through, now you see that placebo flatlines. So if you are a depressed child whose mother has current or history of depression, you don't do well if you get no active treatment. All 3 of the active treatments were superior to placebo. So starting with the combined treatment, the dashed dot line, you see a significant decline. The PEP monotherapy, the dashed line, you see a significant decline. And in the dotted line, for for omega-3, again you see a significant decline, all compared to placebo. We also looked at psychosocial stress and basically found those same kinds of findings. And so again, to orient you, the red line is the rate of remission. And here we see that all 4 groups improve if they come into the study with high levels of psychosocial stress. So this is the upper half of the group with higher psychosocial stress. So again, in this study where we provided lots of referrals for services, lots of TLC, lots of attention, everybody gets better with the tincture of time and attention. So you see our combined sample, the dashed dot line, improving, but so does everybody else. Solid black line is placebo, and you see they come down. Again, the dashed line is the PEP and placebo, and then the dotted line is the omega-3 plus active monitoring. However, if families came to us with low levels of psychosocial stress, again, orienting you, here's the 28 remission line, the black solid line, you see that again, if you come in and you're depressed in the absence of significant psychosocial stressors, if you have no active treatment, you don't get better. So we have a flat line on our placebo, and you see that our other treatments significantly outperform. So again, the dashed dot line is our combined treatment, and you see a significant decline in that line, and you see in our PEP significant decline, and you see in the omega-3 a significant decline. In terms of improved behavior functioning, we were particularly interested in kids who sometimes might be called disruptive mood dysregulation disorder, kids with lots of ongoing chronic depressive, irritable kinds of symptoms, and then a lot of acting out. So we wanted to look at changes in behavioral functioning in our depressed cohort. So here you see the combined, well, let's start with placebo. The black line actually goes a little bit up over time. Psychotherapy alone, you see a bit of a decline. Omega-3 alone, the goldenrod color, you see a bit of a decline. And then you see a nice, what looks like a kind of an interactive effect for the kids who got combined treatment in the red line, a significant decline over time. And the effect size for that on the SNAP total score was 0.85. Looking at the SNAP oppositional aggressive subscale score, we see the same kind of finding. Again, we see a flat line on the black line for placebo, not getting really appreciably better. The green line shows psychotherapy or PEP condition decreasing slightly. The goldenrod color of the omega-3 decreasing slightly. And the kids getting the combination treatment in the red line showing the sharpest decline. And again, that was significant with an effect size of 0.79. On the ECB, we found similar results. So again, here's our placebo in the black line, flatlining with actually a bit of a trend going upward. The green line showing the psychotherapy, the PEP condition, gradual increase downward, same kind of gradual increase downward on the goldenrod line for the omega-3, and the sharpest decline again is for the combined kids who showed a significant decline with an effect size on the intensity scale of 1.1. Same on the ECB problem scale, again the black line being the placebo, pretty much a flat line. PEP alone, decline. The goldenrod color, the omega-3, bit of a decline, and the sharpest decline again being the combined group with an effect size of 0.52 compared to placebo. In terms of executive function, we found again pretty much a flat line for placebo, and interestingly we found really no improvement at all with psychotherapy or with the PEP condition. But the omega-3, here we have the dashed dot line. We see a significant decline with omega-3, and for the combined kids also a significant decline, the dotted line. So combined compared to placebo, effect size of 0.67, omega-3 compared to placebo, effect size of 0.49. Similar findings for the two subscales of the Behavior Regulation Index and the Metacognition Index. So combined versus placebo, again our placebo, the black line, our dashed line is the combined, and we get an effect size of 0.7. For the omega-3, the dashed dot line, we get an effect size of 0.45. On the Metacognition Index, again to orient you, here's the placebo, the black solid line, compared to the combined treatment in this dotted line, coming down significantly with an effect size of 0.35. So what do we know about levels, doses, and ratios? We ended up with 64 children who had blood levels at pre and post-test. We unfortunately had 31 with missing blood level data, and those kids coincidentally had a better, stronger response to omega-3. So the first question is, does supplementation increase EPA and DHA in the blood? Yes, in our 7-to-1 ratio, EPA increased 7-fold and DHA increased by half. Linoleic acid and the omega-6 decreased because these are measured as percents of the overall fatty acids. Second question, do baseline EPA and DHA ratios correlate inversely with baseline measures of depression and mania? No, but when covarying age, total omega-3 and the Kitty SADS depression rating scale had a correlation of 0.21. Arachidonic acid, which is an omega-6, had a negative correlation with CGAS. So as the level of omega-6 went down, CGAS went up. Do baseline omega-3 levels moderate response to omega-3? Yes, in the overall sample. As ALA increased, there was an increase in omega-3 improvement on the CDR-SR. And yes, also in the bipolar group, as higher EPA levels were associated with greater omega-3 improvement on the KMRS, however that was not significant. Higher arachidonic acid levels were also associated with greater omega-3 improvement on the KMRS.